Welcome everyone to our journal club this month. We have a very awesome topic on minimum stimulus strategy for diagnosing BPPV. And to discuss this topic, we have one of the authors on this, a very special guest, Dr. Andrea Castellucci. We're so happy to have him all the way, so to speak, from Italia, and we'll let him introduce himself a little bit more.
Thank you, Elena. Thank you very much for inviting me in this kind of journal club, and I'm very honored to be here. And I'm working as an ENT physician in Italy, and my topic is vestibular medicine, and I used to work also with the neurologists and with other physicians from the emergency department to treat acute vertigo. I really would like to give you some tips to understand from the beginning of the examination of the patient if the patient has BPPV from the upright position. So we'll go through this kind of topic with Elena.
Perfect. So we have some awesome slides, great videos we're going to go through, and we'll just move along and start with the fact that in our inner ear, we have the vestibular system, which is our sensing organ for balance. That organ, we have one on the left and one on the right. That sensor sends information via the vestibular nerves to our brain, and that information from the vestibular system gets processed in the brain along with information from our eyes and our joints in our body to give all this information so that we know where we are in space, keep our balance, things like that. Unfortunately, sometimes there's pathology or problems with this system. And in particular today, we're discussing BPPV. This stands for benign paroxysmal positional vertigo. It's a specific type of condition that involves these tiny little otoconia or crystals that we all have in our inner ear balance system. They help us sense our balance, but sometimes they go in the wrong part of our sensor where they don't belong. Specifically, some canal, which is kind of the little tubes that you see in this picture here on the right. And depending on where they go, where they get stuck, if they're kind of in multiple canals, it can be very challenging to help patients with this issue feel better, because our goal is to move these crystals and put them back where they belong, but that's easier said than done in some cases. So we're going to go through this awesome diagnostic process that Dr. Castellucci and his colleagues have developed. So we're going to start on this first slide here. If you want to go ahead, Dr. Castellucci, I'm all ears.
Thank you for the introduction. Yes, we can start saying that BPPV is one of the most common inner ear disorder, and we have the typical sites for the settlement of dislodged otoconia. This is the ampullary arm of the posterior canal, the ampullary arm of the horizontal canal, but sometimes we might face also atypical variants that are not very easy to diagnose. And so sometimes we have also a multi-canal involvement on both sides or in the same side, posterior canal and horizontal canal. So I would say that if we have patients with intense autonomic symptoms, in particular in the first stage of the disease, sometimes it would be it's important to understand from the beginning where these particles are to directly go through the diagnosis and to the treatment of the patient, sparing the patient's useless autonomic symptoms. So the strategies might be the traditional approach that includes whole pipe test, supine hand roll test for posterior and horizontal canal, respectively, to detect if we have to detect the affected ear and the involved canal arm. Or we might use the minimum stimulus strategy, that is the topic of today. That is a kind of strategy for the diagnosis and also for the treatment with the last possible amount of maneuver using an nystagmus guided approach. This is very important because we always have to look the eye of the patient and the direction of the eye of the patient to understand where otoconia are going according to the position of the head. So the key point is the upright BPPV protocol. So this is, I would say, a typical all pipe test, and we go through an airplane maneuver. So in nickel plate test, that's gold standard for posterior canal BPPV. It exploits rapid head movements of the whole trunk from the sitting to the supine position with the head aligned with the involved posterior canal to give otoconia the maximal inertial forces to achieve a maximal flow velocity of the endolymph. So in this case, we use inertia, we use acceleration, we use a lot of things, and it might not be very comfortable for the patient in most cases, in particular for patients in the acute stage of the disease. And the same thing for the horizontal canal. We use supine head roll tests. And according to this kind of maneuvers, we need to rotate the head from one side, 180 degree from one side, and then compare the intensity of the nystagmus on one side compared to the intensity of the nystagmus on the other side by rotating the head 180 degrees to the other side to understand which is the strongest nystagmus and to see if it's geotropic or apogeotropic. And according to the difference of the intensity of nystagmus and according to the geotropism, if it's geotropic or apogeotropic, we can understand which is the affected side and if the otoconia are in the ampullary arm in case of apogeotropic, or if they are in the non-ampullary arm of the horizontal canal in case of geotropic nystagmus, that is nystagmus that goes toward the ground. So even in this case, we use gravity, inertial, and centrifugal forces, and it might not be very comfortable for the patient, in particular in the first hours. In the
Let's talk a
particular,
little
yes,
more about that. I have a couple questions because
sure.
you touched on, a really nice summary of kind of our traditional approach of using a Dix-Hallpike test and using this kind of Pagini-McClure or supine roll test to try to identify the type of BPPV, meaning which canal, right? Is it posterior canal? Is it horizontal canal? And then trying to determine which side is the affected side. Now, you mentioned a few times the ampullary and non-ampullary arm, and a little bit about kind of atypical versus typical BPPV. And I know many clinicians that I've spoken with have trouble kind of grasping what that really means. So if you don't mind, if you could explain just briefly, and I might go back a slide actually to that nice picture that we had here,
Yep.
kind of I don't have a way to laser point or anything, but we'll try to describe and say, there's this long arm part, right? Kind of the long, skinny part of each of the
Sure.
canals. And then there's this kind of bulbous, big, round part, right? At the kind of far end, I call it, of each of the canals. And that's the ampulla, and that houses the cupula, which is our membrane that sits at the end of each of these canals and this can give us this kind of stimulus so that we know well, if it's working well, which way we're moving. Or in the case of BPPV, it's getting stimulated from the push of the otoconia, causing movement of the fluid to move that cupula. And if those otoconia are trapped in kind of that ampullary area, they can be trapped on kind of either side of the cupula. Is that accurate?
Sure. Yes, they might be. Sometimes they might settle on one side or in the other side of the cupola, leading to a persistent bending of the cupola. So leading to persistent positional nystagmus that might reverse according to the position of the head with respect to gravity. And in those cases, yes, you have a persistent positional nystagmus that is direction changing according to the position of the head. And those cases are, in my opinion, the most tough cases to treat
Yeah,
because you need, yes, because you cannot use the traditional, I would say, Epley maneuver or Seman maneuver for the posterior canal or the traditional Guffoni maneuver or a barbecue maneuver for the horizontal canal because canalids are still stuck there.
right.
And you need to use, yes, most impulsive maneuver, repetitive impulsive maneuvers to detach this kind of otoconia. Yeah.
Absolutely. All right, great. I appreciate that because again, this is something where I think when you're first learning about BPV, it moving in the arm kind of makes sense. But when you get kind of over to that ampullary area, and depending on where they are and which way they're kind of causing a pull, it can change the direction of the nystagmus. And people start to say, is this even BPPV? Am I dealing with a vestibular migraine or something? Like it can be a bit confusing, right?
Yes, also central pathologies might lead to direction changing nystagmus, usually persistent. And another tricky area is the non-ampullary area of the posterior canal, close to the common
Mm,
cross, where if otoconia settle there, you will not have the typical paroxysmal upbeat nystagmus that you have in the traditional posterior canal BPPV. You have a persistent downbeat nystagmus that mimic the anterior canal epiphysis. So it's not easy to understand, to tell the difference between these two kind of variants. And so sometimes you need to use impulsive maneuvers to transform this kind of atypical nystagmus in traditional nystagmus. So then you can understand everything and you can start to treat properly.
absolutely. And I think that's a great take home is understanding that, we're going to do kind of some different maneuvers to see what we can clear. And if we're doing a really incredible job of maneuvers and nothing's changing, that always leads me back to, is this really BPPV? So we always want to keep that in our minds, right,
Sure.
as we're going through this diagnostic process. All right, so ready for this slide now?
Yes, you can go on. So an accurate identification of the affected site sometimes is pivotal from the beginning. Because as you can see here, I brought the patient in left whole pike, and you can see a tiny downbeat nystagmus. So is it an anterior canal? Is it an apogeotropic posterior canal? But if you see better, on all pike on the contralateral side, on the right side, you can see the typical paroxysmal nystagmus consistent with right posterior canal BPPV. So sometimes unilateral posterior canal BPPV might mimic bilateral or also anterior canal litiasis. So if you would have continued to treat the left posterior
Mm,
canal, you probably wouldn't have gained anything. So it's important to know, it would be nice to know from the beginning which is the side affected.
right. And I think you make an excellent point because I think sometimes people think that, okay, I did a left Dix-Hall pike and the patient had symptoms. And let's say there was a right torsional upbeat nystagmus. You and I are guessing that the person has right posterior canal BBV, but you've just managed accidentally to move the otoconia in the right side while you were trying to test the left. This can happen. Also, of course, you might see a horizontal movement if there happens to be otoconia in the horizontal canal, but you were just trying to test a posterior canal. And I think people mix that up, right? They think, oh, I was doing the left exhalpake, it must be left posterior canal because there was some kind of nystagmus, right? And this is why looking at the direction of the nystagmus, as you pointed out, looking at the eyes and ideally using, if you have available some sort of infrared oculography, things like that, to try to really clarify what's really happening. Would you say that's true?
Great, great, perfect. Yes, exactly.
Got it.
And another thing, can you please go back to the previous slide again?
Yes, of
Okay, and
course.
then go on. Yes, okay. In horizontal canal BPPV, another interesting thing is that, as I said in one of the first slides, to understand which is the site affected, you need to repeat the maneuver at least twice to understand which is the stronger side where nystagmus of the nystagmus. But sometimes the difference is not that big, it's not that evident. So if how which is the side that you diagnose if okay, you can go back on the previous, which is yes, let's okay, yes, like this. So which is the side? You can see here now we are in the left uh, Panini McClure position, and there is this kind of nystagmus. We go back on the other side, and nystagmus is not that different from the other
Yeah.
side. So which is the side affected? You don't know. And as more as you continue moving the head from one side to the other side, particles will, I would say, disperse through the canal.
Yeah.
So they will never lead to strong nystagmus. So which is the site to treat? You don't know. So from upright, you might understand which is the site.
Got it.
And another interesting thing is, as you said, I put the patient in left or pike, in right or pike, like in this case, and it's a posterior canal. No, it's horizontal canal. Look. So sometimes the maneuver that you use for posterior canal will not lead to a posterior canal reference activation, but horizontal activation. So you always need to look at the eye of the patient, as you said.
Perfect.
And finally, something very interesting, very important in my opinion, in particular in the first 24, 48 hours, we need to, if you use the traditional approach, as I'm using here in this video, yeah, sometimes the patient will never tolerate this because you
Yeah,
can see I put the patient back and then up and then back again and then up. I'm trying to see because I'm not very confident in the diagnosis, and the patient start to throwing out. And
right.
so in this case, I lost, and I have to tell the patient, okay, go back at home, take tablets, and come back next day, and I will try to understand what's going on. I'm not
Right.
sure if you have the same experience.
Yes, yes. So it's interesting. I get quite in the hospital. I would say when I used to work in the hospital, we would definitely get patients that are on the more nauseous end, we'll say, because part of the reason they're coming into the hospital is they feel pretty bad, right? So they have these significant symptoms. They say, oh, there's something really seriously wrong with me. I need to go to the hospital. Now, in my outpatient setting where I see patients, they still can get quite nauseous and throw up, but on average, compared to my patients at the hospital, I would say they were less nauseous because they're coming into me. They still want to address the issue, but it's not necessarily as severe a symptom all the time. So you get this range of patients. And in fact, of course, on the other end, you have patients, which we spoke about last month on our journal club, that have no sensation, right? These people with vestibular agnosia. So one good part about that is we don't have to worry about them getting quite nauseous because they don't seem to get those symptoms at all. So it's really a range that I've seen in my career. However, it is important, patients coming in the door, especially telling you, I've already thrown up 3 times, I'm already feeling nauseous, I already feel really, really dizzy, I can barely, walk down the hallway because how I'm feeling. Those are the patients, I think, where your maneuvers that we're about to talk about for minimum stimulus really make especially good sense, right?
Exactly, exactly. You said right, as this kind of approach is very good, in my opinion, is very good in the emergency in the first days when the patients are very have very active symptoms, or as you said, patients very anxious who ask us, please do not put in that position because I'm sure I will have trouble. So it's nice to
Totally.
understand which is yes, which is the side effect, so you directly go straight with the repositioning maneuver.
Yeah, we don't want to make patients feel any worse than we have to. I mean, I know sometimes we need a little symptom to help us guide us in our, clinical decision making, but ultimately as clinicians, we care. We want our patients to feel better and we don't want to make them feel bad if we don't have to. So I think that this sensitive approach for many patients could make a lot of sense. I'm really excited for our next slide here.
Exactly. So yes, you can go on with the next slides. So this kind of minimum stimulus strategy is basically what we said. Is an approach that use mainly gravity. This is why, and this is important to understand. If we want to use this kind of approach, it's not important to see the amplitude of nystagmus or the strength or which is the side where nystagmus is strong. You do not have to pay attention about this because you will just use gravity, and using only gravity you will just need to understand which is the direction of the nystagmus, the plane and the direction of the nystagmus, not the intensity, because the intensity you will it's yes, it's not important for this kind of approach.
So the most important thing, and I tell this to new clinicians and students all the time, is to get a ton of practice and get really good at knowing what you're seeing. Was that a right beat? Was that a left beat? Was that torsional left up beat? What are we seeing? And so if someone's new, and I remember feeling this way, I would look at these videos people were showing me, and I'm like, I see the eye wiggling. That's all I could say is it's moving around, but I didn't really know what direction, and I would mix up left and right for the patient, and I was not very good in the beginning, but that's okay. I had guidance, thank goodness. I had mentorship, and I did a ton of practice. I watched videos online. There are free ones. There are courses available where you can just practice until you suddenly become like you or me, where we're like pretty good now, right? And so we're pretty sure what we see, right?
Exactly, exactly.
Perfect.
Perfect, yeah.
All right. I love it. Okay.
So this is a kind of strategy that was firstly started by Professor Asprella Libonati, who will be the one who organized in Italy the next, not the next, but the Barany Society meeting in 2028, so in Rome.
Yeah.
So everyone, yes, everyone is invited there. And we joined his kind of idea. So myself and Dr. Salvo Martellucci from Latina and our friend Dr. Pasquale Malara from Switzerland, and we joined our work together to to design this kind of approach for horizontal and posterior canal BPPV. So we have these three axes. How can we use this kind of approach with the patient in the right position? We have these three axes. Yes, we have the pitch plane. That's a plane that rotates around this axis, the axis that goes from one ear to the other ear. So we use this kind of moments. Okay, we have the yaw plane, and it's a plane that a plane that turns around an axis that goes from the top to the bottom of my head, and this is the yaw plane. It's not very useful this in the Pride protocol, but it's important to understand that there's also the yaw plane. But we also have the roll plane. Roll plane is very important. Roll plane is this kind of plane exactly that turns around an axis that goes from the top of my nose to the back of my head. So it's very important this for horizontal canal BPPV. Okay, you can go farther, but posterior and anterior canal exactly are not. Yes, you can go farther. Posterior canal and anterior canal are not in this are not aligned to this plane. They are aligned with the plane that it's 45 degrees tilted from one side or in the other side. So we will need to use these new planes. If we use the video head impulse test, we are very familiar with this kind of plane because we have the RALP plane, right anterior, left posterior, or the LARP plane. You can go ahead, yes, the RALP plane. So we will use head rotation along this new pitch plane. The pitch plane is like this, so we will use this. That is the LARP, left anterior, right posterior, or right anterior, left posterior. Exactly. So basically the Pride protocol is the crucial part of the minimum stimulus strategy. So we will start with the head pitch test. And if we see some horizontal movements, we'll go on with the head roll test. Exactly. And conversely, if we see some torsional nystagmus or we do not see any nystagmus, we will increase the sensitivity of the head pitch test by using the upright RALP test and upright LARP test. And in acute stage is very, very possible that we will find it's in most cases we'll see some kind of nystagmus. So we will understand which is the canal affected. Yes, basically this is the algorithm. So we start with the evaluation of the pseudo-spontaneous nystagmus, that it's kind of nystagmus that's sometimes seen in horizontal canal BPPV. If we have time, we'll speak about this. And then we'll go with the head pitch test to understand if the direction of this kind of spontaneous nystagmus usually reverses, or if we have just direction change in nystagmus at the head pitch test. If we have horizontal nystagmus, we'll go on with the upright head roll test to understand if it's a geotropic nystagmus or an apogeotropic nystagmus, and we'll go directly to the repositioning maneuver. Or if we see some kind of rotational torsional nystagmus or downbeat or upbeat nystagmus, we'll go with the upright RALP test or upright RALP test to understand which is the posterior canal affected usually. It might be also an anterior canal, but usually anterior canal just lead to downbeat nystagmus in all these positions, so it's not very comfortable to use it. And yes, so it's very easy to understand which is the canal, so we go directly to the physical therapy. Yeah, you can go
Nope.
on. Yeah. So just to see some videos about minimum stimulus strategy in horizontal canal BPPV. So you can go on with the slides and okay, yes, we can go on upright protocol. Okay, so search for pseudo-spontaneous nystagmus. Yes, this is a nice slide. Why do we have pseudo-spontaneous nystagmus? We know that spontaneous nystagmus is a direction fixed nystagmus due to sudden loss of one side of the vestibular organ on one side, so the nystagmus goes toward the other side. But sometimes horizontal canal BPPV might lead to a kind of spontaneous nystagmus that might mimic unilateral vestibular loss. But and this is due because the horizontal canal is not on the horizontal plane. It's slightly tilted anteriorly, 30 degrees tilted anteriorly. So if we have otoconia here, with gravity, they slightly move to the back side, the back part, the lowest, the undermost part of the canal, leading to a tiny movement, a tiny excitation of the efferents of the horizontal canal, leading to a nystagmus that might appear spontaneous, but we just move the head of the patient in the pitch plane, and this kind of nystagmus rapidly reverse or increase according to the position of otoconia. So this is the first part of the minimum stimulus strategy. That basically is the first part of the head pitch test. So we can go on. Exactly. The second part is the head pitch test, and the head pitch test is very interesting because yes, there are just a few literature if just in case the audience would like to yes, to have some reading. Um, yes, it's basically an nystagmus that is basically a nystagmus that reverse according to the position of otoconia, and we will see some videos. You can you
Perfect.
can go on. Okay, we can stay here. For instance, in left geotropic horizontal canal BPPV, left geotropic, it means that otoconia settle, as you can see in the yes, in this drawing, settle the non-ampullary part of the left horizontal canal. So if we bring the patient with the head in forward head pitching,
Hmm.
otoconia that are in the non-ampullary part, so in the back part of the horizontal canal of the left side, they will go
Hmm.
toward ampulla, and we have to remember that and the lymphatic flow that goes toward ampulla is excitatory for the horizontal canal, horizontal left canal. So there will be a left beating horizontal canal, and this kind of nystagmus will reverse if we bring the patient in backward head pitching. But, and you can go on, but the same kind of nystagmus might be given by an apogeotropic
Mm.
right BPPV of the horizontal canal. Why? Because if otoconia are settling in the part of the canal that is close to the ampulla of the right horizontal canal, if we bring the patient in forward head pitching, they will go away from the ampulla of the right canal through gravity, and
Hmm.
this will be an inhibitory stimulus for the efferents of the right horizontal canal. So it will be an inhibitory nystagmus for the right horizontal canal. So we have a left beating nystagmus that will reverse if we bring the patient in backward head pitching. So we have the same kind of nystagmus, but given by two different forms.
Right.
Ampullary, yes, ampullary on the right and unampullary on the left. So how we can understand which one of these two with the upright head roll test?
Right.
Very easy, very easy. If we bring the ear of the patient toward the left side, we will
Got it.
see a left beating, so it's geotropic. If we see a right beating, it's apogeotropic, so it will be right apogeotropic or left geotropic according to the geotropism. And if you want to go through with the slides, there will be some videos that will be very okay. You can go. Yes, exactly. Left geotropic or right apogeotropic according to the direction of this time was given by the head roll test. Okay, there are some videos. Okay, you can stay here. Oh, you can go back.
Oh,
Go back again. Okay. Yes. Go. Yes. Stop here.
this one.
Yeah. It's going. It's just a little. It's just a little bit slow.
Okay.
Sorry.
Wait for it.
Yeah. Exactly. So look. In this case, forward head bending, and there is a tiny right beating nystagmus.
Okay.
So is it left geotropic? Sorry, is left apogeotropic or right geotropic?
Right.
Backward, it will reverse, but we don't know. We do not know if it's right geotropic, so right non-ampullary or left ampullary. We will understand just bending the head toward the right side of the patient. Toward the right side, the right side is right beating. So it's geotropic. So, and of course, if we bring the patient on the opposite side, it's still geotropic. Great. So we can directly go with Gufoni maneuver or Zuma maneuver or barbecue maneuver. Another example, yes. Okay, look this. Both of them have left beating nystagmus. As I told you, do not care about the intensity of nystagmus, just the
Okay.
direction. And now it's reversing. It's right beating in both cases. But as you can see in the cartoon, they are in different position because in the first case is geotropic, right side and it's right beating. In the other case is right side, left beating, and we have the confirmation going on the other side. So left side is left beating in the first case, left side is right beating. It's very tiny, but it's right beating in the case. So we start in both cases with, in one case is the typical Buffoni maneuver, in the other case is the reverse Buffoni maneuver, also called the Appiani maneuver. Basically is the first step of a Zuma maneuver in the other side, in the other case. Um, Yes, if you have all these signs, you do not need to put the patient in the supine hydral test to put 180 degrees, 180 degrees on the other side to understand which is the most strong, the strongest side, etc., etc.
Got it.
Look at this lady, very symptomatic. Look, backward head bending. She closes the eyes because it's too strong for her. Look, but it's left beating nystagmus. Look, even with closed eyes, we can see a left beating
Yeah.
nystagmus. So left beating nystagmus is right geotropic or left apogeotropic. So probably if you bring the patient forward, she will start to throwing out as she's doing. So
Right.
we can directly go with the roll test to understand if it's geotropic or apogeotropic. It would be better to understand if it's that nystagmus will reverse in forward head bending, but of course it was history very consistent with BPPV. So right side, right head roll test, right beating, tiny right beating. So it's geotropic because we are on the right and it's beating on the right. Now we are on the left and it's tiny nystagmus on the left. So okay, it confirms that it's a geotropic nystagmus. So we can directly go with the Guffoni maneuver as I'm doing. This is just a cartoon um, that tells you where otoconia are. So backward at bending, left beating, roll on the right, right beating. So it's right geotropic. Of course, also on the left side is geotropic. So let's go with the Guffoni maneuver on the right, on the left side, and stop. And the positive thing is that in these highly symptomatic cases, we can just have one sign in one position of the test, as in this case, just backward head bending, and just on one side of the roll on the upright head roll test. Okay. Yes, okay, you can go on with this. We just had some studies about this, and you can go on, and yes, we can directly go to the conclusion of the horizontal canal BPPV with minimal strategy. So it's minimal discomfort for the patient. It might be enough just one nystagmus on each plane, for instance, backward head pitching or forward head pitching, just to see if, and just one nystagmus in the roll plane in highly symptomatic patients are enough for the diagnosis. But the drawback, the shortcoming of this kind of maneuver is that it doesn't give us um, the chance to recognize the paroxysmal of nystagmus. So we will never understand if it's a persistent or it's a paroxysmal nystagmus because we just use tiny movements that will probably lead you to tiny nystagmus, and you will never tell if it's a paroxysmal or persistent. So in this tricky kind of BPP variants, it's better to use this typical supine head roll test, of course.
Understood. Understood. Yeah, so I was thinking about if I had a new clinician, could I teach this to them out the gate? Like, do you think they'd be good enough at identifying the direction of nystagmus for the tiny nystagmus for this to be effective? What is your experience training?
I would say that if we have, if you are in the first active period, nystagmus usually are strong enough to be identified. And I would say let's start with the we can also start with the upright head roll test. We'll go on on the left side and see a left beating geotropic. Usually in the first days, nystagmus, in particular geotropic nystagmus, are very strong. Okay, geotropic. Let's go on the other side and we will reverse. So right side, right beating, geotropic. Okay, it's a geotropic form of horizontal canal. So which is the side affected? We can just bring the patient backward, and if it's going toward the left side, that will be a right geotropic. If it goes to the right side, it will be a left geotropic. This is very easy. Or if we have an apogeotropic and we bring the patient on the in backward head bending, if it's right beating, it's right apogeotropic. If it's left beating, it's left apogeotropic. In chronic patients, in patients with symptoms lasting more than, of course, days and but I would say weeks, this tiny nystagmus might be not very easy to detect, in particular if we do not use video goggles. If you just use Fresnel goggles with lights, that would be not very easy to understand. But with video goggles, you can understand.
Got it. That's good advice. All right, so you're ready to talk a little bit about this Raup and Larf situation?
Exactly. So let's go further. Yes. Okay. So the head pitch test might be used also for the posterior canal. Of course, if we have a patient with a history consistent with BPPV, we'll never understand if it's a horizontal or posterior. So let's start always with the head pitch test. This is the advice. Head pitch test. Sometimes the head pitch test might give you tiny torsional nystagmus, usually downbeating torsional nystagmus in forward, and usually upbeating nystagmus torsional in backward head bending. But we remember that the posterior canal are not aligned with the with the sagittal plane. They are aligned with the 45 degrees offset axis. So we might increase the sensitivity. As you can see here, the sensitivity of the head pitch test for the posterior canal, it's like 75%. If we want to increase the sensitivity, we might use the Raup test. Look at this lady. This is in the first days, and forward head bending, you can see downbeat nystagmus. Tiny downbeat nystagmus with the tiny right torsional component, tiny right torsional component. And if we bring the patient back in backward head bending at the head pitch test, this is the traditional head pitch test, we can see that this downbeat right torsional nystagmus reverse, and it's upbeat left torsional nystagmus. That is a typical nystagmus for the left posterior canal BPPV. Okay, so we do not need to add anything. We directly go with the Saman maneuver or all pike maneuver. I use now Saman maneuver, and I rapidly go uh, to the confirmation of the diagnosis, as in this case, left posterior canal BPPV, and it's confirmed by the typical Saman maneuver. And I use the Saman maneuver as well, the treatment, the Saman repositioning maneuver. You can go on with the slides, but sometimes the canal affected is not detectable with the pitch test, so we might increase the sensitivity just bending the patient with just turning the head on one side or on the other side and still going in this direction. So not this direction, because this will never help you, but this direction, like this, because in this with this movement we are aligning our left posterior and right anterior with the pitch plane, or right posterior and left anterior. Of course, there might be also anterior canal etizer, but we know that anterior canal etizer is very is very less likely
Right.
to have. Exactly. Look at this lady. No nystagmus in neutral position. Forward head bending, nothing, and also backward head bending in the ordinary head pitch test, nothing. So probably there will be a posterior canal BPPV. Let's try to test the RALP and LARP plane. Okay, now we go with aligning the head of the patient with the left posterior canal or right anterior canal. So in the RALP, right anterior, left posterior. No nystagmus. So probably she doesn't have a left posterior canal BPPV. Let's align the patient with the LARP. So left anterior, right posterior. Forward head bending, not so much, probably a tiny downbeat nystagmus. But as you, maybe a tiny downbeat nystagmus. If we bring the patient back, look, immediately, oh, nice nystagmus, upbeat nystagmus. And even if we do not tell if it's right torsional or left torsional, in that position could just be right torsional. So it could just be a right posterior canal BPPV because we are aligning the patient with the right posterior canal. So even if the patient closes the eyes, you can see anything, but you say, oh my god, it's it's spinning. Okay, it's right posterior canal. So we can go on and according to this kind of treatment, yes, we can go on. We performed a study, and we found that the diagnostic sensitivity of the upright BPP protocol for the posterior canal was 100% in patients presenting within the first 7 days from symptoms
Mm.
onset. It reduced to 78.9% in patient examined later. Of course, if a patient has symptoms that last more than, but I would not say more than 10 days, I would say more than months. Of course,
Yeah.
autoconi probably they will be a little bit dispersed, so you need impulsive maneuvers, also impulsive diagnostic maneuver, acceleration, inertial forces, so traditional approach.
And the loaded Dix-Hall pike, which I find to be very helpful in patients who come in and they say, "Yeah, it was really bad 2 weeks ago, and then I just kind of saw if it went away on its own, and then my husband or wife said I should go, get it checked out. So now I just felt a little bit in the morning this morning when I got up, that kind of thing, right?" So those folks, I might do the loaded Dix-Hall pike, which you might be familiar with.
Great, exactly, exactly. So for posterior canal, minimal discomfort for the patient, high sensitivity mainly in the acute stage, and of course there is a low sensitivity for other less common variants like cupulorethiasis. In cupulorethiasis, you need strong acceleration to impart to the cupula to be deflected, and also apogeotropic posterior canal BPPV or anterior canal BPPV that will just lead to downbeat nystagmus in both head bendings, and you will never understand which is the side. So in this case, okay, of course you need traditional approach, but in
Right.
typical acute stage, let's use this and stop. If I
And I
have
think,
just, sorry,
go
yes,
ahead.
yeah,
I was just going to say, I think this is a great way as someone starts out and they're new, maybe they can only just handle learning a couple maneuvers at a time or a couple tests at a time when I'm training someone. But, as they get more experienced, it's great to say, well, in this case, what's the tool in our toolbox? And this is true for testing, in my opinion, as well as treatment. So I have someone coming in and they're very sensitive. This is a great tool in the toolbox. If it's someone who's like, I don't have any dizziness, but I'm falling all the time, I'm probably going to do a Dix-Hall pike or a loaded Dix-Hall pike because they're not feeling the symptom, but I want to make sure I elicit the nystagmus if I think they might have BPPV causing their falls. So you're kind of making those decisions. And I love this red light, yellow light, green light analogy, actually, because it really helps us kind of make decisions about what is the next kind of right thing to try, versus also for treatment, right? You might have say, okay, I think this treatment is going to be the best choice for this patient, but you can try it and it doesn't work. And so this is why I think there are multiple maneuvers for treatment, right? Because sometimes someone will respond well to one and not another, or they don't have good head neck mobility, so one maneuver is not going to work, or you have to get creative with how you do it, right?
exactly, precisely. Great.
Perfect.
Just last video for multi-canal BPPV. I think this kind of approach could be very useful in multi-canal BPPV because, for instance, post-traumatic BPPV, post-traumatic positional vertigo, usually they have multiple involvement. So look, I'm using a RALP, a right anterior left posterior, and there is a tiny downbeat now, and then upbeat nystagmus. Okay, in a few seconds we will see a upward left beating. So for sure she has a left posterior canal BPPV. Okay, this is just the drawing that highlights what we have said, what we have seen. But let's we do not need to put the patient also in the contralateral whole pike. Just use tiny movements to test also the contralateral posterior canal. So LARP, left anterior, right posterior. Look, both sides, both posterior canal. So in this case, it's very important to understand before treating the patient to know from the beginning if you have just one canal affected or more than one canal affected. Because if you have both posterior canal affected, maybe it's better not to use Epley maneuver, but maybe it's better to use a Simon maneuver because Simon maneuver just exploit the plane of the canal that it's affected, that it's being treated. Airplane maneuver, you use multiple planes, and maybe you will disperse also the otoconia on the other side. So I'm using all pike. Sorry, I'm using Simon maneuver that is much more comfortable. And if you use Simon maneuver, you can treat both posterior canal in the same examination, at the same time. You can see now the liberatory nystagmus. And since we saw a liberatory nystagmus for the right posterior canal, we just try to we can just check, but we know if we saw the liberatory nystagmus, we are pretty sure that there is no more BPPV in the right posterior canal. We're just checking, and there is nothing. So okay. So we can start with the left posterior canal BPPV treatment. So we bring the patient in the other position. And since we already know from the beginning that she had both sides, okay, for sure. Now she has left posterior canal BPPV, and we start with the Simon maneuver also for the left posterior canal. Okay, just
And this
enough.
is
This
a
is
great opportunity to
yeah.
ask you a question. So I have had clinicians say, well, I was trained by whomever to only treat one canal per session if there's multi-canal. Pros and cons to treating both canals on the same day. When would you make that decision? How would you make that decision?
I would say that if I always okay, if there is a lateral canal and posterior canal on the same sides, I will try to treat both of them if they are on the same side because it will be easy to tell the patient, okay, lay on the other side to help at home to help otoconia to go back in the utricle. If we have both sides, I always used to have your kind of approach. I usually used to treat one side and then on the next examination check if everything's okay in that side, and if everything's okay in that side, I would start to treat the other side. But if we use Epley maneuver for, I would say, for instance, the right posterior canal. When I do the Epley maneuver and I put the patient in the second position and in the third position, I always mixed up things on the on the other side. So I started to use Simon maneuver in this bilateral posterior canal, and if I see the liberatory nystagmus in the liberatory Simon position, I started to continue treating also the other side.
Yeah. I think my only hold on multi-canal is, of course, tolerance, right? So if a patient pretty clearly can only tolerate treating the one canal that day, then I just try to get them back into outpatient. This is not at the hospital, of course. So is that,
Sure, 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 sure. Yes,
yeah.
multiple canal. In particular, if the patient has lateral canal is very symptomatic. they usually start to say, okay, please stop, let's start, let's go
Pause
on.
button. Yeah, which is we got to respect. That's understandable. So yes.
Exactly.
So yes, if the patient's tolerating the treatment, I always say, I will continue until I think I have everything clear. I'll continue to treat until I run out of time or until I've got everything clear. That's kind of how I approach it, unless the tolerance isn't there, and then we'll kind of spread it out a little more.
Perfect. Yes, yes, definitely agree. So, in conclusion, if I might say a few words, just a few remarks. So, minimal stimulus strategy is an nystagmus guided approach. Very important, a nystagmus guided approach. Never trust the patient. Okay, I'm spinning. Okay, in this side, so it will be a right posterior canal. No, always look which is the direction of the nystagmus, and based on slight head movement, just enough to move free floating particles, mainly explaining gravity. So never rely on the amplitude of nystagmus, but just on the direction of the nystagmus. It has been developed in response to the need for better tolerated and non-invasive diagnostic approach to BPPV to minimize patient discomfort, in particular subjects with important autonomic symptoms and anxious traits. Since it has maximal diagnostic sensitivity in the active period, in the first days, it should be always pursued in those patients with recent onset BPPV and autonomic symptoms. And basically, it should be preferred when there are factors which might potentially prevent to achieve a correct diagnosis and to complete the repositioning maneuver if the affected side and canal are not correctly predicted before starting repositioning maneuver. This is very important because if the patient is very anxious, very symptomatic, and you fail in detecting the canal and the arm affected, probably you will need another session to start to diagnose the site and start treatment.
Understood. Understood. That's awesome. All right. Well, thank you. I agree. Thank you.
Yes, thank you. This is the group of the advisors of the Italian Society of Vestibular Medicine. So I would like to say hello to all of you from my colleagues.
Yes, yes. And I would like to say that we have wonderful researchers all around the world trying very hard to sort out different ways to help our patients who are suffering. And I particularly know that great research has come out of Italy, and particularly under the umbrella of BPPV research, as well as peripheral hypofunction research. So I just want to express my particular gratitude as a clinician treating patients, that I've been able to help many patients because of the work that comes out from all around the world, but very much so our colleagues in Italy. So I thank you, Dr. Castellucci, as well as this team here and everyone out there who's trying hard to help our patients feel better with these challenging conditions like BPPV.
Elena, thank you very much. Your words are very, very nice for us, and it's actually yes. I'm just one of the last, one of the last person in this huge group of people studying a lot the BPPV. Yes, we have, Italian patients are very, they are very. They say so much. Oh my God, I'm spinning.
Yeah,
We-
they express
we-
themselves. Yes.
Yes, very much. So, since we do not want to hear all their words, we're
Oh,
trying to treat them with
yeah.
gloves. We say with gloves. Okay.
Oh. Very motivating to help our patients
Exactly.
feel less bad. We want to help them as much as we can and have them as little negative symptom as possible. That is everyone's goal, I believe, as a clinician. We'll wrap up this journal club now. I hope that everyone can kind of process, practice, mull over how you might use minimum stimulus in your practice for the right patients. It could be a real game changer. So I encourage you to look back, watch back, read the articles, whatever will help you. And feel free to reach out to myself or at Helena at vestibularfirst.com. And then, of course, I can always point questions, or you can directly contact us. Well, Dr. Castellucci provided his email here for you as well. So if you have specific questions, we're happy to help. So we thank everyone. Thank you again, Dr. Castellucci, for joining us so much. We really appreciate your time and for helping your patients and the world to better treat our patients with vestibular issues.
Thank you very much, Lena. Thank you for reminding me. See you.
Thank you. Take care. We'll see you at our next Journal Club, everyone.